All right, welcome to this high-yield medical explainer. Today, we're zeroing in on thyrotoxicosis and hyperthyroidism. Now, if you're gearing up for your AKT GP exam, or honestly just looking to bulletproof your daily clinical practice, you are absolutely in the right place. We're going to lock down those crucial diagnostic and treatment protocols so you can totally streamline your revision. Let's just dive right in, shall we?
So, here's our roadmap. We've structured this explainer to mirror your actual clinical pathway. We'll start off with definitions and key stats, move into clinical features and causes, then map out the diagnostic pathway and your initial primary care management. Finally, we'll wrap up with definitive treatment protocols and, of course, those absolute must-know AKT exam pearls.
Okay, Section 1, Definitions and Key Stats. Before we even think about prescribing, we really need to grasp the true, heavy burden of this disease. And to understand why we've got to be so vigilant, just look at this number, 400%. Overt hyperthyroidism is definitely not some benign condition you can just sit on. It carries severe long-term consequences, including up to a massive 400% spike in all-cause mortality. Your patient's cardiovascular mortality risk alone jumps by 20%, right alongside a higher risk for osteoporosis. And the really scary part, this mortality risk keeps climbing the longer they stay hyperthyroid, completely regardless of the treatment you eventually use. So early identification, it is absolutely vital. Now, for your exams, you've got to nail this distinction. People toss these terms around interchangeably all the time, but actually, scratch that, they really shouldn't. Thyrotoxicosis is the whole overarching state of excess circulating thyroid hormone. It doesn't matter where it came from. Hyperthyroidism, on the other hand, is just a subcategory. It specifically means the thyroid gland itself is working in overdrive, actively oversynthesizing and secreting that hormone.
So think of thyrotoxicosis as this giant umbrella. It can definitely be driven by hyperthyroidism, like Graves' disease, but it can also be triggered by drugs like amiodarone, exogenous thyroxine, or even rarer things like Ostruma ovarii. But here's the kicker. Regardless of the pathway, they all funnel down to create the exact same clinical picture. We're talking tachycardia, atrial fibrillation, heat intolerance, weight loss, the whole shebang.
All right, moving right along to Section 2, Clinical Features and Causes. We've got our definitions locked in, so let's talk about what's actually going to walk through your clinic door.
80%. This is an absolute must-know statistic for your revision. Graves' disease accounts for a staggering 80% of all thyrotoxicosis cases. It is by far the biggest player here. So statistically speaking, when you're looking at a hyperthyroid patient, Graves should be front and center in your mind.
So how do we actually spot it? Well, when a patient's profile matches these key demographic and autoimmune features, your clinical radar should be pinging like crazy. Graves is an autoimmune condition, right? Autoantibodies bind to TSH receptors and basically hijack the system, forcing unregulated T3 and T4 production. It usually hits patients between 30 and 60 years old, and it's a whopping 6 times more common in females. Also, definitely look out for smoking. It's a massive, modifiable risk factor, and examiners love to test that. Oh, and keep in mind that thyroid eye disease, conjunctival erythema, periorbital edema, proptosis, that shows up in about 40% of these patients.
But hey, don't let toxic nodular disease or thyroiditis catch you slipping. Toxic nodular disease usually shows up in older adults. These are just benign nodules going rogue and over-secreting hormone. Thyroiditis, though, that's a transitory trickster. It's an acute inflammatory phase where damaged cells just dump all their stored hormones straight into the blood. The gland is usually pretty tender, but the good news is it typically resolves on its own in about 1 to 4 months once those stores run dry, and you'll often see a hypothyroid phase right after.
Okay, let's jump to Section 3, the diagnostic pathway. We're going to break down the exact cognitive steps you need to safely assess these patients right there in primary care. The Red Whale guidelines are fantastic for this. They lay out the super clear 5-step primary care assessment framework, so you never miss a dangerous complication. It's pretty straightforward. Step 1, assess the severity. Step 2, exclude complications like heart failure. Step 3, hunt for red flags for malignancy, like a rapidly enlarging nodule or hoarseness. Step 4, try to establish the cause by checking for a goiter or eye disease. And finally, Step 5, get those investigations going. Now, looking at the full flowchart for those investigations, NICE is incredibly explicit about this next point. Checking TSH receptor antibodies, or TRAbs, is recommended in absolutely all patients with thyrotoxicosis. Why? To confirm Graves' disease, of course. If those TRAbs come back negative, then a technetium scan of the thyroid gland in secondary care is very likely your next move.
Let's circle back to Step 1 for just a second, assessing severity.
You've got to be hypervigilant for a thyroid storm. This is severe, totally uncontrolled hyperthyroidism that leads to multi-organ failure. You're looking for tachycardia, fever, delirium, dehydration. It can be kicked off by surgery, amiodarone, or even just abruptly stopping anti-thyroid drugs. Listen, it carries a mortality rate of up to 17%. So if you even suspect a thyroid storm, that is an immediate, same-day hospital referral. Literally, no exceptions.
All right, on to Section 4, Initial Primary Care Management. So once you suspect a diagnosis and you've cleared those acute safety checks, what exactly are your immediate responsibilities as a GP?
Our initial response is actually pretty clear. Yes, all hyperthyroidism gets referred to secondary care, but you aren't just sitting there twiddling your thumbs while they wait for a specialist. You can totally consider symptomatic treatment, like beta blockers, to get that tachycardia and tremor under control, assuming no contraindications, obviously. You can also think about starting anti-thyroid drugs. But if you do go that route, there are some massive, massive safety caveats.
Here's the deal. Before you ever write that script for an anti-thyroid drug, checking a baseline full blood count and liver function tests is an absolute medical legal requirement. You're guarding against severe risks like liver dysfunction and granulocytosis. Now, carbimazole is usually going to be your go-to treatment. However, you'll want to switch to propylthiouracil or PTU if your patient is pregnant, planning to get pregnant in the next 6 months, or has a history of pancreatitis.
And guys, you absolutely must drill this next point into your brain, not just for your AKT exams, but for your daily practice. Patients require explicit, written safety netting. They need to know, without a shadow of a doubt, that if they develop a sore throat or a fever, they must stop the drug immediately and get an urgent full blood count. Agranulocytosis hits about 5 in every 1,000 patients, and if you miss it, it can literally be fatal.
Okay, Section 5, Definitive Treatment Protocols. Let's do a quick run-through of the secondary care definitive treatments, just so you know exactly how to counsel your patients on what comes after your referral.
So, for adults with Graves' disease, NICE actually recommends radioactive iodine as the first-line definitive treatment. Really? You only avoid it if there's a specific contraindication, like pregnancy, active thyroid eye disease, or if it's compressing neighboring structures. Now, if it's a super mild, uncomplicated case, they might be offered a 12 to 18-month course of antithyroid drugs. And a total thyroidectomy? That steps up as the primary option if you suspect any malignancy or if compression is causing major issues.
Almost done. Let's bring it all home with Section 6, Crucial AKT Exam Pearls. For this final stretch, we are focusing exclusively on those high-yield safety alerts and diagnostic pitfalls that examiners just love to throw at you. Take a good look at these MHRA warnings for carbimazole. This is classic exam fodder, for sure. First up, carbimazole crosses the placental barrier, which means a real risk of congenital malformations, especially during that first trimester. So women of childbearing age absolutely must use highly effective contraception. Second point, acute pancreatitis. It's rare, but it happens. If a patient develops it, you stop the carbimazole immediately, and you never, ever restart it. Why? Because re-exposure triggers a rapid, life-threatening recurrence.
Now, here is a question that trips people up all the time. What about biotin? You know, the over-the-counter hair and nail supplement. Why on earth does vitamin B7 cause so much absolute chaos in the endocrine clinic?
Well, biotin interference is basically the ultimate exam gotcha. High doses of this little soluble vitamin can completely skew a thyroid panel. I mean, it causes a falsely low TSH, a falsely high T4 and T3, and even a false positive TRAbe. On paper, it perfectly mimics Graves' disease. It's wild. So if the clinical picture just isn't matching these drastic lab results, you've got to ask about biotin. And your very first action? Stop the supplement, wait 2 to 7 days, and retest.
Let's wrap up with a crucial clinical scenario because it really ties everything we've talked about together. Your hyperthyroid patient on carbimazole calls your clinic reporting a sudden sore throat. You need to know exactly what might be happening in their bone marrow. You are racing to rule out agranulocytosis, an absolute wiping out of their white blood cells by the antithyroid drugs, leaving them completely wide open to overwhelming sepsis. They need to stop the drug and get an emergency blood test today. Understanding the why behind these protocols is what makes you a genuinely safe doctor, and it's exactly what the AKT tests. Keep this structured approach in mind, use these visual pathways, and you're going to navigate the thyroid cases with complete confidence. But before you go, ask yourself this. If a simple over-the-counter vitamin like biotin can perfectly mimic Graves' disease on paper, what other everyday supplements are silently sabotaging your patient's blood panels right now? I'll leave you to think about that. Catch you in the next explainer.